Welcome to episode 155 of the Daniel Yoris podcast with today's guest, Dr. Carri Dominick. Let's go. Welcome back to the podcast, everybody. Joined here today by Dr. Carri Dominick. Carri, thank you so much for being here. We're going to have a conversation about something that is brand new on the podcast, which, I mean, there's hundreds and thousands, maybe millions of topics to discuss in the realm of health and fitness and wellness. And sometimes you get in the bubble of thinking like, hey, it's, you know, we're 150 plus episodes in now. We've kind of done it all, but apparently we haven't. So we're going to talk about something new today.
Yeah, thanks for having me. I'm excited to talk to your audience about what I do.
Of course. Well, can you go ahead and give us a quick introduction of who you are and what it is that you do?
Yes, so I'm Carri. I'm a physical therapist, but I specialize in treating the pelvic floor. So what that means is I help people a lot with like bowel, bladder issues, pelvic pain. So I treat a lot of women. I treat men too, but mostly women. And so I'm excited to talk to you about what that means in the context of fitness.
Absolutely. So right off the bat, again, keep in mind, I know very little about this other than the basics of anatomy and physiology that just, go across all of training. But based on what you just said there, bladder, bowel, these things, like men and women both have bladders and bowels, and we all, use these things and go to the bathroom and all this stuff. Why is pelvic floor therapy so much more prevalent or needed or maybe seeked out? Is seeked a word? Seeked. It's not sucked. Seeked out?
Sought out?
Sought out. There you go. Sought out by women.
Yeah. You're right. Like we both have bladders and bowels and we essentially have the same pelvic floor muscles, but the anatomy is a little different. Is there visuals to this or this is just audio? Yeah,
no, it'll be visual. I mean, most people listen audio only, but it'll be on YouTube. Yeah. So if you want to show stuff, feel free. And everyone, when Carri's showing stuff, go to the YouTube to show it.
I'll try to explain it to you, but I'm a visual learner. So we're going to see some anatomy if you're watching this. So
yeah, I'll do my best to translate to the visuals for you audio only people.
So I'm going to compare to you. These are not exactly the same, but we're looking from the bottom of the pelvis. Like if you're standing up, you're looking from the ground up. So this is a male, and this is a female. If you can see them. So the shape is kind of the same. I need another hand. But we kind of both have this triangle shape around the penis and then around the rectum. And then for the females, we have this triangle shape. So we're looking at the muscle there. Mm-hmm. Triangle shape around the vagina and then around the rectum. Those are your pelvic floor muscles. So we call them pelvic floor because they make up the floor of the pelvis. And if we look at this.
Clever little scientists.
Yeah. Because so I'll tell you, people used to ask me, like, does this have to do with floor exercise? Like exercise on the floor?
Interesting.
Which is a good question, right?
Yeah, valid.
But if we look at this, like, model of a spine and a pelvis, the bony structure, at the bottom is just muscles. Like, these are our sits bones, right? And there's really nothing else. So that's why we call it pelvic floor muscles. So that's what I'm talking about when we talk about the pelvic floor. But there's a couple differences. So obviously women have a vaginal opening and men don't. So that just puts them at more risk anatomically for bladder issues. Women also go through pregnancy, which, like, if they have a vaginal birth, that all gets opened up and sometimes torn or cut, and surgically repaired. So more risk. And also women have a lot more hormonal fluctuations, right? So not just their normal menstrual cycle, but then when they go through menopause, that also affects the vaginal tissues. So those are like the two major differences when we look at the visuals. But also there's some anatomical differences inside. So in a female, like, these are the female parts. So the bladder is below the uterus. So it's in that order, stacked inside. But in a male, the prostate is below the bladder. The bladder's on top. Mm. And so those anatomical differences sort of put more women at risk of bladder issues, pelvic floor issues. There's just more going on. If you look at the base of the female model, like, there's another whole, there's more holes in the muscle structure, right? So that just inherently makes it more at risk or weaker, or at risk to be weaker. Or males, they just have the rectal opening, and then everything else is like continuous. So those are the anatomical differences that really make women more often need pelvic floor therapy than men.
Right. Makes sense. And I think that visual is super helpful. So anyone who missed that, like, just go back. We're very early in episode, go to the YouTube video of this and just look at the models. Now, my next line of thinking here is like, we have pelvic floor issues. What are some of these quote unquote issues, and what would be, I guess, a symptom would be pain, although that's quite general. What are some of the conditions that constitute a pelvic floor issue?
Yeah, so in the realm of pain, I do have patients that have pelvic pain, and often it's related to sex. So for women, like with penetration, they have pain. And so usually that means like the muscles around the vagina are tight, right? So normally they relax, they expand. They're meant to do that, right? They're meant for penetration. They're meant for babies to come out. And that also can happen to men, but it's much less common. But some of my male patients might have pain with erection or ejaculation. And again, these muscles are the same, and they surround the penis and they go like on the length of the penis. So that's like a common pain thing. But there are some other like pelvic pain issues. So for some of my patients, and I'm relating this back to fitness because I think that's probably your population, right? So some of my patients, it's sort of like exercise will increase that pain because things are already tight, and then we're lifting weights, we're like turning on those muscles. So for those patients, I try to tell them like, you can exercise, but like at the end, we need to like down regulate, we need to stretch, we need to breathe. So that's a common pain one, but a lot of the pain is really more specific to sex, intercourse, penetration, things like that. Yeah, but I have had males with pelvic pain with exercise too, so it's not just a female thing.
Yeah, I mean, it's something that I've definitely like come across in passing. I can't recall a client that I've ever had that's like, this was an issue, or like anything that he or she had like expressed that ended up being that. So it hasn't been very common to me, but I've definitely heard in passing people say like, oh, my pelvic floor is tight. And to me, when they say that, they just like do nothing about it. And so I think they're just like using words that they don't understand. And like, maybe it's true, but maybe it isn't, but they're not doing anything about it. So I'm like, well, what does that mean? Just like, okay, go stretch. Like, I guess I don't like, they're not asking me for advice. They just like throw it off as an offhanded comment. Like, oh, when I can't do like, lateral lunges because my pelvic floor is tight. So I'm just going to stretch. I'm like, okay, all right, but you're not doing anything about it. So like, what are you calling? I think people are just making up words, and probably a big misunderstanding of what actually it is and why it's tight and how to go about it.
Yeah, I agree. I think it's become kind of a buzzword. Like, I'm glad people are talking about it, right? And hopefully they're seeking help. But I think, these terms are out there and people are just saying this. And yeah, like, what does that really mean? So there is an anatomical pelvic floor muscle, but these are really like inside layers of muscles. They're not something like from a training perspective that you're going to work on. But yeah, like those patients, I do tell them like, we do general stretches, like the adductors, the inner thigh muscles, they're like the most direct attachment to the pelvic floor. So I have a lot of people do, if they have pelvic pain, a lot of like stretching of their adductors, right? Just all the muscles that attach to the pelvis, right? Stretching their piriformis, their glutes, all of that, their hip flexors maybe. So that does help. And then, I think a lot of these people, at least what I see in the clinic, like they're kind of like anxious people, really like upregulated if we talk about the nervous system. So they're just like always on the go, right? So it's sort of like they have to get their like nervous system and their demeanor to like calm down because they're always on. So I think that contributes a lot to like pelvic floor pain.
That makes a lot of sense because the muscles are not, I mean, they obviously move, but the bones that they attach to, don't move. It's not like your bicep, which connects to, your shoulder and your elbow, and you can touch it from the outside under your skin, and like you can clearly and easily like stretch and flex it. But your pelvic floor muscles, like your pelvis doesn't like separate. And I mean, I guess it could, but like you can't consciously just like do that and separate it and bring it back together and exercise it, quote unquote. So the only way to get at it is by going around it through the other muscles that are attaching to the bones and kind of relaxing the whole structure. But I think this brings up a good point of tension, and we're all like sitting a lot and very tense. And I think that a lot of people, I catch myself doing this sometimes, you're sitting a lot, and for some reason we're just like clenching our glutes, like squeezing our butt for no reason. And it's kind of like this nervous, anxious thing. And maybe when you're really focusing on something, and is that sitting posture and that anxiousness, that just like holding tension in your muscles for no real good reason, is that something that contributes to some of these issues?
I think it can, but I would say like you said, like most of us do that at some point. I think the people that end up with pelvic floor pain, it's a higher level of that, right? It's like, it's more than just, I realize I'm clenching my butt. But I would say like in the pandemic, like 2020, when everyone was at home all of a sudden and didn't have good work setups, I had a lot of people with pelvic pain because they were sitting. But that was sort of extreme, right? It's like all of a sudden you're at home, you have this makeshift workstation that you thought was going to be 2 weeks, and then it was a whole year.
3 years.
And yeah, years. We're still there somewhat. But it was sort of like people didn't move at all, right? Like they just got up, walked to their living room, and sat for like 10 or 12 hours. And I think after some months, we sort of realized like, okay, this is going to be for a while, and we made some adjustments. But I think in that extreme case, it does contribute to that. But I would say for most people, just sitting and realizing like you're clenching and stuff doesn't usually contribute. It's usually more extreme, or there's some other factor, like a medical factor, something else.
Right. Got it. So would you say that there are a lot of people, because it sounds like to me that there are probably a lot of confounding symptoms that go along with pelvic floor pain, and it may be disguised as something else or not understood. Like when people are feeling the symptoms, whatever those might be, they're not understanding what they're feeling. And so they might think, oh, like my hip hurts, or my glutes hurt, or my stomach hurts, or something like that. Is that a common thing that you find? And then eventually through process of elimination, or finding someone who's good at what they do, like you or their doctor or whoever, then they can realize, oh, this is like a pelvic floor issue, and I can seek the correct help. I don't know, that's kind of a long-winded question, but does that make sense?
Yeah, it makes sense. And I think, yes, it can be. And I kind of like we touched on before, like all the things around it contributed to it, right? So it's not like your pelvic floor is tight in isolation.
Right. It's
sort of like probably everything around it. So I think a lot of those people can get better with general help from a trainer or a physical therapist, to work on those things. But I would say like my patients that have pelvic pain, it's like, it is very specific. So yeah, it's like pain with
So you would know right away is kind of what I'm getting at. Yeah.
Yeah.
Okay.
Yeah. Most people, it's very specific. It's not general hip pain, but I would say if they have pelvic floor pain, they probably have hip and back pain too.
Understood. But they would have that pelvic, like I've, have hip pain and tight hips, and these things have happened, but I've never had that. I've never had a feeling that feels like it's in my pelvis, that I imagine internally in my brain, I'm imagining what it would feel like, and it would feel very unique. Yeah. And not like a regular muscle tightness or muscle strain or muscle whatever injury. It would just feel so strange that it kind of feel like, oh, this is different. This is not a regular thing. I might also have something else, but like this part is different.
Yeah, like a lot of men tell me it feels like I'm sitting on a golf ball. So yeah, it is a very unique feeling, and it's very specific, and it's pretty disturbing, and that's why people seek help, because I'm like, nobody wants to come to pelvic floor therapy and have their pelvis worked on. Right. It's also very non-sexual. Like, I think some people think pelvic floor therapy, like, I have a lot of friends that make fun of me, and I'm like, it's like the least sexual thing you could do, even though sometimes we're working to like have better sex, but it's very clinical. But yeah, it's very specific. So people are really like, it bothers them. So that's why they're looking for help. And right. A lot of my patients, they're like, it's interesting. A lot of the males find it on Reddit and a lot of females find it on like the internet or social media. I think just sort of like where we spend our time. But it's really disturbing to them. It's really like, affects every part of their life. So, it's not a general hip or back pain. On occasion, I've had a few patients who are like, I have this back pain and I worked with my trainer, I went to physical therapy and it wasn't that. And for those specific people, it probably is pelvic floor, because sometimes we'll touch a part of the pelvic floor muscle and it's like, oh, that's my back pain, or, oh, that's my hip pain. But those are the exceptions. Most people, it's a very specific sensation.
Yeah, that sounds like it would be unbelievably uncomfortable and something that as soon as it started, you'd be like, yep, I need to see someone today. Not like, oh, I'm just going to tough this one out. Like, that's not a tough it out kind of ordeal.
Yeah, exactly. Yeah. For this kind of pelvic pain, it is.
So what does some of the therapy look like? I got to imagine there's some amount of manual therapy involved, plus stretching and exercising and breathing is probably a big part. Maybe we can kind of cycle through those things, down the chain as far as, however you go about treating. But what does therapy look like?
Yeah, so that's a good question, because this is a very foreign thing to a lot of people. So I tell people, I'll explain everything, and then I tell them, like, you can choose to do it or not do it. So, if people are comfortable with it, I'll do a pelvic exam. So for women, that's internally, vaginally, because these muscles are really felt inside, right? Because these are your sits bones. So, like, we're at that level, like your glutes are layers and layers out here. So they're really like 1 or 2 knuckles deep inside. So I tell my female patients, like, it's similar to going to the OBGYN, but they're bypassing the muscle layer. They're just looking at your cervix and your uterus. But really just inside, I want to feel the muscles to feel like, is there any tension, tightness, tender points? Can you do a kegel? And so that's important. I think kegels are overprescribed, but it is important in some cases.
We'll come back to that.
Yeah. I want to feel like, can you do a kegel? But I'm also looking for quality of muscle versus just, can you do a kegel? So like, do your muscles turn on when we want? Do they turn off when we want? How strong is it? But also like, do they turn on enough when we want? Or does it get stuck on? Or do you not even know how to activate that muscle? Which is definitely common with people that come for physical therapy because they have a problem. But I also tell people, like, these muscles, just most of our life, just do their job and we don't have to think about them, right? So it is hard to know, like, am I doing a Kegel right? But I would say if you don't have dysfunction, like, you should be able to activate those muscles. Like, I can just do it while I'm sitting here but this is what I do every day. Right. But there's 2 things that make it hard. Like, number 1, those muscles are just automatic, and most of the muscle fibers are automatic. They're part of our autonomic nervous system, but we do have volitional control over them, so we can work on them. And number 2, they're hard to work on because there's nothing to see, right? Like, kind of like you touched on earlier, like your biceps or your legs, right? Like, you can see the movement, you can see the muscle, but there's nothing to see, really. Like, they do move a little bit, but not a lot.
Not as much as bending your arm or
exactly. Like, you can just, like, see yourself doing it. Yeah. So I do
thankfully you can't do that.
Yes, exactly. Like, the pelvis is a very strong structure, which is good. We need that. Except in pregnancy, we could talk about that, how that sort of shifts. But yeah, so I do a manual exam, and then I do something called biofeedback. And for a lot of younger pelvic floor therapists, I don't know why, they're very anti-biofeedback. I think it's because I've been in this field for 17 years, so I've seen some trends, right? If you've been in any field long enough. I think when I entered the field, it was pretty young. And that's kind of all we did with people. We hooked them up to this biofeedback, which I should have brought it. I could show you. But it's these sensors. I use these sensors that go on the muscle. They go on the skin. So they're picking up the muscle from the outside. And they show on a little screen, like, the muscle activity. So it kind of becomes our visual. And I find it really helpful. My patients find it really helpful. So you can sort of see, that becomes your eyes of what the muscles are doing. So you can see, like, how strong are you? And are you relaxing? There's, like, some benchmark numbers. So I do that. And then I kind of look at people globally too. Like, I look a lot at, like, spinal and hip mobility and flexibility. And then strength, I'll test in physical therapy, we do something called manual muscle testing. It doesn't really have like, it's not really standardized. There's a standard, but it's pretty subjective.
Yeah.
And
but it's relative, right? It's like, flex your right arm and then flex your left arm. Are they the same? That's how it is, right? And it has valid like clinical tools, but it's not I get it.
Yeah. So I use it. Yeah. I use it in that sense. Like, oh, this one really works and this one doesn't. Or I'm looking for like, oh, does this, resistance like create pain, right? Or reproduce your symptoms. But I also like to test people functionally too. Like, what does your squat look like? Can you do a single leg squat? And is that different side to side, right? Because in the big picture, if there's imbalances in these muscles, like our bigger muscles, then that's going to affect our pelvic floor, right? So if like, I could do a single leg squat on my left leg, but my right leg, I'm all over the place. And then I have pelvic pain inside. So a lot of times what happens in those small pelvic floor muscles, like I tell people, these are small, tiny muscles. These are not your big stabilizing muscles. They are part of your core. But if our big hip muscles, let's say, are not doing their job, then sometimes our pelvic floor muscles get tight because they're trying to do the job of the bigger muscles. So sometimes even with pelvic pain, I'm like, we need to strengthen your hips. And we need to get this muscle better balanced, and that will take the pressure off the inside smaller muscles. Because that's not their job. But if a bigger muscle is dysfunctional, then sometimes, our body's smart. It's going to like figure out a way to do things.
Yeah, totally. This comes up in a lot of different types of injuries where sometimes weakness is masked as tightness. Your hamstrings feel tight, or your hip flex, probably most common in the hip flexors, right? Whereas people feel like, oh, my hip flexors are so tight, and maybe they feel that way, but they're also probably extremely weak from being constantly shortened and not really work because you're not sprinting or climbing or using them in any like real way. And then when you start to strengthen them, then all of a sudden they feel looser, and like that pain or that tightness feeling is alleviated. But like you said, the body is very smart at protecting ourselves from hurting ourselves further, and or reorganizing movement to make it happen in whatever the most efficient way is at that moment, but doesn't mean that it's overall the most efficient way to do it, because we typically don't move correctly.
Yeah, exactly. We're going to get it done even if we're not using the optimal muscles.
Right. So are there any like other modalities, or maybe this is a better question actually. Why do the new school people not like the biofeedback? Like what's the hold up here? It seems like it's an EMG. It seems fine. It probably doesn't tell you everything, but it tells you something. And like, why would you not like that? It takes 2 seconds, not invasive.
Yeah, and I really think it goes back to when pelvic floor therapy was like a new thing. That's sort of like the first training you take is like how to treat bladder leakage, incontinence, and you just do these exercises with biofeedback. And so that's like what pelvic floor therapy used to be. It's just a whole session of working the pelvic floor muscles. So I think sort of the younger therapists are like, no, we got to look globally, which yes, absolutely I agree with. Or they just use manual techniques. So I think some of them, they're just feeling the muscle as they're like feeling the people do kegels or whatever. And to me, that feels like invasive. And like, if we could do this in a little more comfortable way, that's why I use it. And then my patients actually really like it because they can see what's happening.
Right.
And I think that's really helpful for people, especially people who aren't really in tune with their body. Some of my patients are really athletic. They're really in tune. And some of them have no idea. So if you don't know how to like move your body in general, like there's no way you're going to know how to like work pelvic floor muscles that you can't see. So yeah. I think it comes back to that is like that used to be the whole treatment. But to me, it's like a piece of the treatment, right? So it's an assessment tool. And then it sort of tells me like, do we need to work on something with this? Or is this not the issue? We got to work on something else. So, to me, it's a really effective, tool to use. And I think that's the thing is like, it's just, should be a piece of the testing and treatment, not like the whole thing. Cause yeah, you gotta, to me, for any physical therapy injury, you've got to reintegrate that back into what you want to do.
Makes sense. Makes sense to me. I mean, there's so many things, like there's so many tools, and I think people get caught up on like, well, is this the whole thing or is this just one tool? And just because I use this tool doesn't mean I don't use other things or I ignore other things. Like we can hold two ideas or two concepts or two modalities in our head at the same time. And if one of those things, maybe that biofeedback, like for whatever reason, really doesn't work with one patient, but the next patient, they really respond to manual therapy, and another patient really responds to verbal cueing or whatever it is. Like everyone is different, and this is like most of the job of the coach or therapist or practitioner is like figuring out how to apply the things to that patient. I remember like this was a while ago when I was like a much younger, not that I'm very old, but a much younger trainer, like very early in my training career. I was doing squats with this one female client, and I was telling her to squeeze her quads on the way up. And she kept like not doing it. And I kept saying it, like thinking, this is, young, new trainer, like dumb. Just like if I say it enough times, she'll figure it out. And then she kind of stopped and looked at me. She's like, you keep saying squeeze my quads. I don't know how to do that. And I was like, huh, interesting. Like, all right, let's see. And I like said, okay, stop. Like put the weight down. Like try it. She's like, nothing's happening. Like the quad's not moving at all. I'm like, okay, we spent the rest of the session like sitting on the floor, like, okay, squeeze the quad, and like tried a bunch of like visual and tactile cues, and eventually she got it. But that seems like, to me as a young trainer, seemed like a very ridiculous thing. How could someone not know how to do this? I'm 19 years old. How could someone not know how to do this? This is crazy. But of course, she didn't know how to do it, and we have to teach people how to do these things, because using your body is actually quite difficult. And probably like, again, flexing the biceps is the easiest one, but a lot of the rest of the body, we don't have very good control, and gaining that control is really half the battle, and probably goes into a lot of, again, what you do obviously is learning how to control your body and utilize it correctly. But that is a very difficult task. So aside from like the tactile cueing, the biofeedback, what exercises or if there are any exercises that are maybe, things that people might be able to understand, do you do or think that would be a good idea for people to do to start to understand how to use their pelvic floor muscles and stuff like that and control themselves?
Yeah. So yeah, like I think the best cue for a lot of, especially women, is sort of like hold back your urine, like squeeze. So like you're going to not pee yourself. Right. For men, often a better cue is sort of like, what do they call it? But I tell them like lift up the tip of the penis. Like that helps them activate. I've learned over time. It took me some practice with men because the anatomy is a little bit different, right? So for women, they're like, oh yeah, I know how to like squeeze so I don't pee myself, right? But I think for men, that's like not so much a thing. But sort of telling them to like lift up the tip of the penis, like that usually works. Or sometimes for men, what do they say? Like nuts to the guts, like squeeze your nuts up. So those are usually the cues that work for men. But that's your pelvic floor. So I think a lot of people that don't know how to work their pelvic floor, they end up squeezing their glutes, right? Like they're like, okay, I'm just squeezing my glutes or their inner thighs. Or when I'm assessing a patient, I'm looking at this too. When I'm telling them to squeeze their pelvic floor, a lot of times it's abs, it's glutes, it's inner thighs. Sometimes it's even quads, right? Like they're just looking for anything, especially if it's weak, right? Like you see that in training, right? If someone's really weak, they're like, I'm going to squeeze everything. And so in therapy, we work on isolating the pelvic floor muscles, but I tell people like, that's actually not real life. Like our pelvic floor muscle does not just work in isolation. Like, yes, maybe there's times like we need to like really squeeze tight so we don't pee ourselves, right? If we make it to the toilet. But in general, our pelvic floor is the bottom of our core. So it does work together with our other muscles. So if you don't have dysfunction, you don't need to work these muscles because they're part of your core. So they're getting worked all the time. And I'll, when I have the biofeedback on people and they're laying down, if they move, it's like, the biofeedback goes off. And I'm like, see, your pelvic floor, it does pick up artifact, other muscles, but the pelvic floor automatically engages like with every step we take, right? When we're doing squats, when we're working out. So I think there's this big misconception, like, especially for women, like you got to do kegels for the rest of your life. But no, you don't. And that's sort of my philosophy with anything in physical therapy is like, we should work on it in isolation, but then you should sort of incorporate it into your general workouts or your life, if you have a shoulder injury, like, you probably don't need to do those shoulder rehab exercises forever. Like, hopefully you're going back to the gym and just doing general shoulder workouts. Maybe there's a few things we got to be mindful of, but to me, the point of physical therapy is like, we don't have to do this forever. We fix the problem, we reintegrate it, and then we're just doing the other thing. So
yeah, if you have to do it for forever, then you obviously didn't fix the problem. So like, what are we doing here?
Yeah.
Can't just be in rehab for forever.
Yeah, exactly.
So you've referenced Kegels with like a heavy asterisk, let's say, a couple times now. Define what they are for anyone who might not know what it is, and tell me about your thoughts on when people should use them, why they're a little bit overprescribed, and all the rest.
Yeah, so Kegel, it was named after like Dr. Kegel or something.
Oh.
That's why they're called that. Yeah. Like, that's how a lot of scientific things get named, is sort of like whoever discovers it, it's named after them. But really, a Kegel is just contracting the pelvic floor muscles. So, and it's using those muscles. So, we do a bicep curl, right? Or like a squat or whatever, like we're using those muscles, a quad set. A Kegel is just squeezing those muscles. So, yeah, but kind of like I just said, I think they're overprescribed because, really, they should just function normally, and we don't need to do them if there's no dysfunction. And the other thing is, like, so kind of, we talked a lot about pelvic pain. If you have pelvic pain, your muscles are probably already tight. And so we don't need to tighten a muscle that's already tight. And yeah, so I would say pelvic pain is a little bit different than sort of the example you used of hip flexors. So it is true, a lot of muscles are tight because they're weak. And that can be true in the pelvic floor, but we sort of need to like calm the muscles down, soften them, and then we see like, are they working normally, or do we need to then strengthen? But, so I would say tightness does cause weakness, but again, the pelvic floor is a little bit different because it's much more part of our autonomic nervous system than our like general skeletal muscles that we volitionally exercise. So yeah, anyone that has pelvic pain, it's like, don't do Kegels, because things are probably already too tight. But another caveat to that is I would say sometimes if people do have pelvic pain, I use Kegels sort of in reverse, because if something's tight, it's hard to just tell your muscle to relax, right? Mm-hmm. So they sort of, in a lot of like meditation stuff, right, they have like progressive relaxation exercises, sort of you go through your whole body, like tense it up, relax it, right? So I kind of use Kegels in that way for some of my patients. But otherwise, like if you don't have dysfunction, I don't think you need to do Kegels, because those muscles should be regularly activating with normal movement.
Right. I guess so. To summarize that, and from what I'm hearing from you is that a lot of the misconception with Kegels is that pelvic pain or pelvic floor issues, as an umbrella term, means do Kegels, and that is incorrect. Like it's another tool, and it could be useful. It is often useful in many scenarios, but not always, and not all the time, and not for forever.
Yes, that is good. That's a good reminder for me, because I'm sort of in the bubble. But yeah, I think that's like what people hear, like, oh, you have pelvic floor dysfunction, you need to do Kegels for anything. Yeah, like if you have bladder leakage, if you have pelvic pain, it's like Kegels are the thing. But really, like, obviously this is my specific training, is that Kegels are not the only thing. Right. They are a tool, but they're not for everyone, and they're not the only thing, and they're not forever.
I think that the flex and relax, or this dichotomy of things, is really helpful to understand how to do something that you can't feel like you're doing. Like the opposite of the only way to understand what light is, just understand dark, fast, and slow. Like all these things that are opposites of each other, right? You can't really understand one without the other. And sometimes relaxation is that thing as well. Like muscular relaxation is like, okay, it feels tense, and I know you're saying the words relax, but I can't do that. I'm obviously trying to, and again, 19-year-old me, like, hey, you said do this. I fucking heard you. I'm trying. It's not working. But sometimes, like you flex it, and it's like, okay, that's what more tension feels like. So then understanding that helpful to understand, well, the opposite of that is what I'm trying to do. And then so you can get into the relaxing. And I think that, what I want to kind of get into now is the breathwork aspect of this, because breathing is very related to your nervous system. This is, listeners to the podcast know this, we've talked about this all the time. Our mutual friend, Phil, we had a great conversation about this on the podcast. But how does breathwork, how is it involved in pelvic floor therapy?
Yeah, so number one, it just sort of, if we get into like that deep breathing state, then it relaxes our whole nervous system. So a lot of times people that have pelvic pain or tension, like everything's tight, right? So if we can sort of get them to get out of that state, that will help, number one. But also, I wish I had a picture of the whole thorax, but when sort of the diaphragm and the pelvic floor sort of are parallel. And so when we breathe, the pelvic floor can relax as we breathe and expand. So again, some people who are really tense, really tight, or just not really in tune with their body, it's kind of a hard concept, right? To get them to actually breathe into their diaphragm, breathe into their abdomen, and not just like up here, right? Where I'm just like taking these shallow breaths. But if they can get to that, then the pelvic floor is going to actually lengthen a little bit with those big breaths through the diaphragm. So it's kind of twofold. So the nervous system, but then there is actually a lengthening and a movement of the pelvic floor with those nice deep breaths.
Yeah, breathing is also a mechanical exercise, which people often forget or don't realize maybe that there is like a muscular component to breathing, and you can utilize that to your advantage in scenarios exactly like this. Do you have any favorite breathwork protocols or kind of go-tos that you use for yourself or patients? I mean, obviously it's going to depend on the person in a prescription basis, but any general recommendations for people?
I really try to get people to lay down and relax, and I often have people put a hand on their chest and then a hand on their abdomen, and then I'm looking for if you're laying down and this is the chest and this is the abdomen, are they moving equally, or can we get more into the abdomen? I think that feedback really helps people that aren't aware of where their breath is. Yeah. And I try to just have them put their hands on it, and then I try to ask them, do you notice anything? And then, are you breathing more into one hand or the other? And then can you reverse that? And if people have never, used their diaphragm and breathed into their belly, a lot of times then they're, pushing air. So we got to kind of, work on that. So those are kind of my go-to techniques. And then it comes down to individual. Everyone's different. And I kind of find with some of my people who are really, in the internet, they're doing a lot of research, they're on social media a lot, they kind of have the opposite problem. Everyone has their nuanced way of teaching this, right? It's sort of belly breathing. No, you have to breathe laterally, the ribs, 360 breathing, right? And it's very confusing to people who are reading a lot or watching a lot of videos. And so those people, it becomes actually more forced, and we have to sort of come back and find some different ways to do it. And so I often start on the back, but I actually recently took a class and they talked about, for those people who are really tense, having them sort of leaning over, standing up, leaning over something and trying to relax their belly there. Because a lot of people that have pelvic pain, pelvic muscle tension, their abdomen's really tight, right? They don't breathe through there. Everything's just on all the time. So it goes back to, just working with humans. Everyone's different, and you got to figure out what cues, what position, what technique works for them. But I find a lot of times if people can be their own biofeedback, right? Biofeedback is just body feedback. It doesn't, not a machine. That's one form of biofeedback I use, but their own feedback of using their hands, I think really helps people to kind of feel what their body is doing.
I agree. And it comes back to a lot of that control that we've been talking about this whole time of your whole body. Can you breathe into your belly? Can you breathe into your shoulders? Can you breathe into your chest? Can you inhale? Can you hold it for a little bit longer? Can you slowly exhale? Can you do all these things? And okay, now we've got that control piece down. We can mix and match all the protocols, and you want to argue over, breathe into the ninth rib or this rib or the whatever, this degree angle, hold the breath for 4 seconds or 7 seconds. That is all secondary and matters, but not that much kind of thing.
Yes, agree.
So something we mentioned earlier, and I kind of want to switch gears into talking to about, not because it's personally interesting in my own personal life, but because I'm sure there are people listening to this who will kick me if I don't ask you and talk about this. But what are the considerations with pelvic floor, not even therapy, just pelvic floor at all in regards to pregnancy? If someone is planning to become pregnant, are there things that they should be preemptively doing either, before pregnancy or during the pregnancy and after? There's obviously, maybe we'll talk about that second, but is there anything that people should be considering before or during pregnancy in regards to their pelvic floor?
Yes, good question, because that's a lot of my population that I see. So in general, I tell people if you want to become pregnant, you should start strength training before pregnancy. Because one thing I see is people come in, especially if they've never worked out, and then as they're growing in their second and third trimester, their back hurts, their hip hurts, and it's like, so hormonally what's happening is like our pelvis is normally a very like strong structure, but the hormones are starting to make that relax. And for some people that happens way sooner in pregnancy and some people don't. But again, our body has sort of these backup systems. So our bony structure is like the number one, and then our ligaments are number two, and then muscles. So the ligaments start to relax due to hormones. And so if you don't have strong muscles to like stabilize your pelvis, then you're gonna, not to say everyone, but you're more likely to have a lot more pain in your pregnancy. So I always think like I should start a pre-pregnancy strengthening program. So I really encourage people, if you've never exercised and you are thinking about getting pregnant, start training and find a trainer who knows. So a lot of like glute strengthening, hip strengthening, because again, there's postural changes and that puts more pressure on your back, on your hips, on your pelvis. So strength train. And that also sort of keeps the pressure off the pelvic floor. So in pregnancy, I really encourage everyone, if you have access, see a pelvic floor therapist during pregnancy to assess your pelvic floor, all the things that we talked about. And we can sort of optimize you for birth. So do you know how to push, which is another thing we didn't even talk about, but, a birth, like really your uterine contractions are what pushes the baby out, but, are your pelvic floor muscles going with that, or are they contracting, right? So I tell people like, it's a normal reaction when something hurts, we tighten. We got to sort of like overcome that in pregnancy. And I think again, the hormones and the physiological process helps that. But
it's
also
like a push and a relax at the same time.
Yeah. So yeah, like normally a kegel, right? A tightening, a contraction of the muscle, we pull up and in, but, you can also push out. So sort of like when you're pooping, things push out. So kind of same concept. So we go over that. We test that. We train that. And also like I look for in pregnancy, like, do you have any muscle tightness? Because we want to work on that so that those muscles can soften, stretch, expand, right? If there's tightness, it's more likely that's going to tear. You're going to need stitches, right? All the things that come afterwards. Also that can slow your labor down. So a lot of like, especially dancers, gymnasts, people like that, who are taught like everything, like hold everything in, right? Like that's their whole life. Like you gotta look beautiful and like hold everything in together. Sometimes they really struggle when it comes to childbirth because they don't know how to relax. So we can train those things. We can work on those things. So I encourage everyone, if you have access, see a pelvic floor therapist, hopefully in your second or early third trimester, even if you don't have any issues, because we can proactively work on those things. And in the US, our healthcare system is not proactive, but you can choose to pay and do that. And it can really help you after birth, with the birth, right? And hopefully avoid C-section, but C-section is sometimes medically necessary. So I always say that's sort of probably a medical thing, but sometimes like your dilation, your labor can't progress if everything's really tight. So seeing a pelvic floor therapist, we can work on that to help your labor hopefully be as good as possible. There's something called perineum stretching. It's basically like, perineum is this part between the vagina and the rectum. And so we kind of stretch these tissues, because this is where things are going to open up, right? Like there's bony structure on the top, but this is where things are going to open up. And if there's tearing, it's probably in that area. So,
just to interrupt you quickly, for anyone who's just listening visually, the model that Carri's holding up, you can very clearly see that at that point that she's talking about, there's the most width. So there's the most, like the widest part of where the muscle is. So there's more room for it to stretch. And that's kind of what she's more referring to there with the stretching of that.
Yes. Sorry. I'm a very visual person.
It's okay.
I know this is
You're
audio.
doing great. This is my job, is to be
So yeah, we teach them that. And then, you know, like, yes, we test kegels, but we teach stretching. And then also I tell people, like, you don't have to live with back pain or hip pain during pregnancy. Like, physical therapy can address that, or your trainer maybe, you know. And if people are seeing a trainer, I try to say, like, okay, we need to work on this. Like, we need to strengthen this, we need to stretch this, and give them specific exercises. And then I think also people think like, oh, I'm just going to have bladder issues if I'm pregnant or postpartum, because in our healthcare system in the US, that's sort of, I think this is kind of worldwide. It's sort of like, this is what happens if you have a baby, but this is what pelvic floor therapy works on. And it's like, no, you shouldn't pee yourself for the rest of your life. It's not normal. So we can work on that. So did I answer your question about? Yeah,
definitely. I mean, there's a lot of information there. I mean, I think some of the main takeaways, and I've noticed this a little bit through my own personal experience, is that, like, if you plan to become pregnant ever, not in the next, like, you know, month or couple months, but like if you plan to become pregnant ever, you would do yourself a huge favor by starting to strength train. And I can say, like, anecdotally, I mean, we obviously know this through many, many anecdotes and through research and whatever, but I've trained several women who have become pregnant, and like their main reason for training wasn't to become pregnant. They were already training with me, and then through that process, after however whatever, then they got pregnant. Their pregnancy was smooth and, like, you know, all good. And we adjust the training, but it's not like I've never started training someone who, like, came to me at 3 months pregnant and said, hey, I want to start training. I probably wouldn't accept that person as a client, because that's a very special situation, and not, you know, especially if they haven't been working out previously. But if they've been working out, different story. All that to say, as again, summarizing kind of what you were saying, is like just general strength training, making your body stronger, looser, more limber, more control, is going to make the pregnancy easier, or at least give yourself the best chance for the best pregnancy possible, right? With anything, there's always an element, any number of things can go wrong, and, you know, you might do everything right and things still might go wrong or not perfectly or whatever, but you want to do your best to give yourself the best chance to give yourself the easiest, most pain-free, healthiest, safest pregnancy possible.
Absolutely. Yeah. I'll give you one tip for trainers. So this is a common thing in pregnancy. So back to my visual. So the pelvis is basically one structure, but there is something called the pubic symphysis, sort of in the front of the pubic bone, kind of holding things together. This is normally a very, very strong, stable structure, but sometimes during pregnancy, this sort of becomes loose, and like the two halves of the pelvis have a little bit of movement. So for some pregnant clients, if they're getting like crotch pain, sometimes they call it like lightning crotch, or they're getting pelvic pain, it could be from this. And so often what brings that on is single leg things, split leg things, wide leg exercises. So if you're training someone who's pregnant and they're having a lot of pelvic pain, I'm like, that's the time not to do single leg stuff. So I have patients occasionally come to me and they're like, all of a sudden I have this pain. I've been training, right? I've been working out. And so that's maybe a time, like, not do single leg stuff, like cut back on lunges, split squats, things like that, and sort of double legs together. So we kind of give that more stability. So that is one common thing I see in pregnancy that can help. People.
That makes a ton of sense. And for anyone, you know, training themselves while pregnant, like, pay attention to these things, because pain is not normal. Like, pain is always an indicator of like, hey, something's going on here. Don't just ignore this. Like, you shouldn't do this at any time, but especially while you're pregnant. If you're having pain, especially with exercise, like the right answer is not just, you know, bite down on your teeth and suck it up. Like, figure out what's causing that pain. And so if it's that thing where the pelvis is, for lack of a better word, and a little bit too extreme, but splitting, and like that, the different rotation in a like a split stance exercise, a single leg exercise, is causing that pain. Like, yeah, pay attention to what you're doing and maybe stop doing that. It sounds very simple to say and silly, but like I'm sure you see tons of people who are like, it hurts, but I keep doing it and it keeps hurting and I can't figure out what's going on. It's like, well,
Yeah, and luckily I've worked with some trainers that are like, why is my client having this problem? And then I'm like, oh, this is the thing. This is how you adapt your training. So I think a lot of trainers are well-meaning, but they're not aware of this, right? Unless you really work with this population a lot. But if you're a trainer, you're probably going to work with pregnant women at some point or women who have had a baby. So yeah.
Are there any other considerations that people should just preemptively be aware of, or things that they should avoid while pregnant in training?
That's the big one. And then also people talk about not laying on your back. And you can lay on your back for like short amounts of time, right? So I still have people doing bridges, doing things like that. I think there's also sort of like, oh, you're pregnant, you can never lay on your back, right? But it's like you can for short times, and your body will tell you if it's uncomfortable. Like you'll have symptoms like, so the big red flag would be like lightheadedness. That's like restricting blood flow. That's why they don't want you to lay on your back when you're pregnant, but it's usually later in pregnancy. Those are really the only two big ones, like the pelvis splitting. Oh, I also should say, there's something called diastasis recti, which is like the abdominal muscle splitting. So what that will look like is sort of like the middle of the abs sort of poke up like a tenting or coning or doming, they call it. This is gonna happen in pregnancy. Like everyone who gets pregnant is gonna get some degree of this. That's normal. But what I tell my clients and trainers is like, we don't want to, if we're seeing a lot of that when we're doing like abdominal exercises or core workout, we want to not do that. That means that exercises is now too hard. The abdominal muscles can't control it. You're probably not going to make it worse. That was like, diastasis recti was like this big thing for a while, and I feel like it's not such a big thing anymore. But some people who are really into fitness, who are on a lot of forums, they'll see this and they're really like freaked out about it. So I think it's something.
It's a scary sounding word as well.
Yeah. And it looks really odd if someone has a big, like you'll see it. Yeah. But you're not going to make it worse. Exercise didn't cause it. The pregnancy is just the adaptation and the muscle stretching. But it does mean we need to change what we're doing. Like now that's too hard because during pregnancy, like you should still train the core. It just is going to look different. So maybe you have to do standing or, a different position. And then sort of as pregnancy progresses, I don't love, things where the belly is down, like planks and stuff. Like that's okay for certain amount of pregnancy, and I don't love that early postpartum because I think it's too much on the abdominal muscles, but you can still train it in other ways. You got to get a little creative sometimes, but don't be scared of it. But if you see that, just know like we got to adapt.
Makes sense. Other than the not maybe doing exercises where like belly is down or face down, what are some of the other training considerations? Again, all this is like in general, right? Contact someone and like, figure out your own stuff, blah, blah. Yeah. But training considerations for postpartum women.
Yeah. So postpartum, I think I see way more women postpartum. So kind of like we said, you should strength train before pregnancy. You should strength train first postpartum. So I think postpartum, there's a lot more issues that come up, depending on how the birth went and how recovery went. So, and again, I think most healthcare is like this in the US. It's like, don't do anything until 6 weeks. And then your doctor says you could go do whatever. It's not a switch at 6 weeks. You can start, depending on your recovery, like your early days and early weeks should be rest, but you can start exercising. And I think again in US healthcare system, it's like, don't do anything but walk. And for some people, if they have a lot of pelvic floor issues, sometimes walking doesn't feel great for them. Just being on their feet that long, it feels heavy, it feels weak. So I tell people like, you should start with body weight strength training. And you can start 3 or 4 weeks postpartum if you want to, if you're feeling good. And everyone should start with strength training before they go back to running, jumping, more intense exercise. So that's really what I work on a lot with postpartum is people want to go back to their HIIT classes, to running, right? Like, I want to lose the baby weight. But it's going to be a process to lose the baby weight. Like, you gain this weight over 9-10 months. It's not going away in 6 weeks or 3 months.
And those things don't really help lose the weight anyways, but that's
yeah,
a conversation for another day.
Yeah, you're just stressing the system. But postpartum, yeah, so definitely strength train. Get your core back, but I work a lot on hip strengthening, glute strengthening, because your pelvis widened during pregnancy, during childbirth, the hormones, like all that stuff. And if you're breastfeeding, you're still going to have this hormonal component that's going to keep the weight on. You need a little extra body fat to breastfeed. But strength train. And then there's some general guidance. We're starting to do some research in this area, but it's very new. So sort of the general guidelines are like not doing impact exercise like running, jumping until 12 weeks postpartum. And then there's some testing. I can send this to you. You could post it. There are some guidelines out of Europe there's some tests you can do to see, like, are you ready to run and jump? So it's like you should be able to walk for 30 minutes and have no pelvic floor symptoms. So this is kind of pelvic floor specific, but you should have no pain, no heaviness, no bladder leakage. And then you should be able to do like 20 reps of like heel raises, bridges, squats. And then you should be able to do like single leg squat, single leg bridge, single leg heel raise. And then you should be able to do like 30 seconds of jumping in place, hopping in place.
I feel like most people couldn't do that even before they have a baby.
Yeah.
It seems like quite the recommendation. I mean, most people should be able to do that, but I whatever.
Yeah, you probably see this.
The average fitness level is quite low.
Yeah, so you probably see this. So like these are like the general strength things you should be able to do to run and jump. And then you put in a pregnancy and whatever happened with birth and recovery. So there are guidelines. They're not, we're doing research on them, but they're guidelines. And I use those guidelines, and sort of. So yeah, you should start with strength training, add a little bit of impact, test out single leg, because a lot of postpartum pelvic floor issues come from that, whether it's bladder leakage or pelvic pain is sort of like, oh, this one leg is weak. And often this goes back to way before pregnancy, right? Like whatever we had going on in our body just gets exacerbated in pregnancy and postpartum. So we got to work on those little nuanced weaknesses and imbalances we have in our body. And that's going to be the best thing for our pelvic floor, but also give yourself time to recover, to regain your strength and stability before you're really pounding, running, jumping is like a huge impact on our body. So strength train.
Yeah, there you go. I mean, that all that recommendation seems very logical and like it makes a ton of sense to me. I mean, you should go back to activity again, correct me if I'm wrong here. You can go back to strength training as soon as you feel comfortable. Strength training doesn't mean go in the gym and hit a deadlift PR. It means start moving your body in whatever way feels good and comfortable. And it's not totally dissimilar from a training perspective of like, if someone was injured, then when you go back into the gym, we don't just like start hammering that part of their body again. Like we start where they are, which is very regressed, and then we just like slowly ramp it up using body weight or very light external weights or regressions of exercises or whatever the training modality is. But like treat it like that, where it's like, hey, you're getting back into this. When you're getting back into something, you don't start at your maximum effort. You start very light, very easy, and you work your way back. That's yes. All correct to say, more or less?
Exactly. Yeah, it's exactly like that. And I think people who are working with a trainer one-on-one are going to get that, but it's sort of the people who are like going back to these group fitness classes and there's no individual instruction and they're just like, I'm going to lose the baby weight. I'm going to like go do what I used to do. But yeah, hopefully most trainers are considering that and working in that fashion. So yeah, it's sort of like you went through this thing. It wasn't an injury per se, but your body went through this process. And so yeah, we got to sort of start where you are and build up. Yeah.
Going into a group fitness, I've been very critical of group fitness classes for a lot of different reasons, but going into that postpartum seems like close to the worst idea that you could have. I mean, there's definitely dumber things you could do that would almost certainly cause you an injury. But like, it's gotta be up there. Like, there's no specificity, no control. You already don't know what you're doing. That's why you're going to a group fitness class. And then they also don't know what you're doing and doing all the wrong things at the wrong intensity. It seems like a recipe for disaster. But
yeah.
I'll
also,
put
I would
myself saying that, you know?
Yeah. But also say there's a lot of group fitness classes for moms, which is great, but they're generally not trained in the early postpartum. Like, you know, it's sort of like you're just going back to their group fitness. Like, yes, it's for moms, but it's not necessarily for the early days. Like,
right.
They might scale it, but what I've seen, and hopefully they don't call me out, but I work with a lot of like group fitness moms fitness groups, and I there's definitely a place for it, but those early days, like, you really got to sort of build up slowly.
Yeah, I agree. I mean, I think that's also just a little bit of marketing misconception, right? Like, group fitness for moms is great. That is not the same as group fitness specifically for postpartum moms or immediate postpartum moms. I know some people who are in that field who train postpartum women and they do some group fitness type stuff, but it's not like your regular group fit. Like, I would never go to that class because I'm a man and I'm not postpartum. And a woman who's not postpartum also wouldn't go to that class because it's not for her. It's for specifically postpartum women. And that would be like obviously a fine group exercise thing to go to. But we're talking your regular, like your F45 Orange Theory, you know, rah, cheerleader, do as much as you can in as little time as possible. That's not the thing for you.
Yes.
Honestly, outside of all this, it's not the thing for most people, but again, conversation for another day.
Agree. It keeps us physical therapists in business.
This is true. Carri, this has been awesome. Is there anything that you think that we've missed or that you really wanted to say? Again, understanding my lack of knowledge and line of questioning in this entire topic. I feel like we've covered a lot. I personally have learned a ton, but is there anything else that you think that we really need to talk about before we close it off?
I mean, I could talk for 2 more hours, but I would also say, if you're working with women at any age, and a lot of training clients are women, I think have an awareness and kind of come up with your own way to ask them, do they have bladder leakage? Do they have pelvic pain? Have they had a pregnancy? Like, even women like 20, 30 years later, like, this sort of affects them, or are they in menopause? There's, so we didn't talk a lot about bladder leakage, but that's really common with, training. So sort of like, again, making sure they're breathing, not holding their breath is my like number one go-to strategy. But, I think, if you can make a way to that, you obviously have to not feel awkward to ask these questions. But if you can add it to your intake forms or whatever, I think women really want to be understood and they want to work out, and often they're told, like, we just have to deal with this, right? Like, maybe I pee when I lift weights, but I'm just going to deal with it because I want to get stronger. I want to be in shape. So I think if there's a way you can sort of incorporate this into your conversation, like in whatever small way, that feels comfortable to you, I think, your clients will really appreciate that. And even just acknowledging or having awareness, like, have you been through pregnancy? Like, have you been through menopause? But you have to be comfortable with it first, because if you're not comfortable, it's going to make it way more awkward. So, I'd really encourage like fitness professionals out there to find a way to incorporate this, and then find some pelvic floor therapists in your area and connect with them. We love to talk about this, and we want to help the field. We want to help people beyond our doors, and we want to help people have good fitness experiences and not quit fitness because of their pelvic floor issues.
Totally agreed. I mean, I think that one thing that a lot of clients, I've had this happen, many, many times, is like, we're going to tell you something, but it's kind of like a little bit too much information. I'm like, it's actually, first of all, it's not. I've heard some crazy stuff. But second, like, the more information you give me, the better. Like, tell me about how your poops are. Tell me about, the stuff, all the crazy stuff that happens. Like, it's important for me to know about that and to be able to like plan around that. Like, these things matter, and your trainer wants to know this, not because they're specifically interested in that thing, but it's because it matters about how we can help you best. And the more information we have, the better job that we can do.
Yes. Love that.
Amazing. Well, Carri, thank you very much for your time today. This has been, again, very, very educating for me, and I hope for a lot of other people. Is there anything that you have going on coming up that you want to let people know about, and where people can find you and all that stuff? We can point them in that direction.
Yes, you can find me on social media at Recharge Therapy, so I'm on all the main channels like Instagram, Facebook, TikTok. So I try to post videos every day and information, like little tips and tricks. Obviously that's not the whole story. It's much nicer to have a podcast where we can talk about this in depth. And I have an online course about bladder leakage, bladder issues. That's sort of like my main online course. Obviously I do a lot in person. I'm in California, a long ways from you. But yeah, I really encourage people to, if you don't have access to someone, a pelvic floor therapist in your area, like an online consult or an online course can give you some place to start with and can help a lot. Not everyone has to be seen and touched in person, but sometimes like we really do. But there are a lot of resources out there. So, or find a trainer who's like, interested in this and like has some information and knowledge. So I want people to get help with these things.
Yeah, no, amazing. And that very much comes through. And I agree, the online stuff, even if you can't find someone in person or you're just not sure, it's a great way just to introduce yourself, to understand, like me in this conversation. It's like, I almost don't even know what to ask you because I know so little about the stuff, you know what I mean? But someone who's like, I feel like I might be having this issue, instead of, if it's not convenient or whatever for you to see someone in your area, finding an online course might even just give you enough information to know what to know about, to know what you should further research or look into or ask questions about. So I definitely think it's a good deal, but I'll link your social media in the show notes for this recharge therapy on all the places. But Carri, again, thank you so much for this. Is there any last message that you want to leave the people with here in closing?
Get help if you need it, and if you're a fitness professional, like find a pelvic floor therapist or physical therapist. We want to be interconnected with you because we want to send our people to good trainers too, who understand this and have awareness. So it goes both ways. So a good physical therapist wants to be connected to their community. So reach out and connect with us.
Beautiful. Awesome. Thank you very much, Carri. Thank you everybody for listening. I appreciate each and every one of you as always. Recharge Therapy, Carri Dominick on social media. You'll find her. The links will be in the show notes. That's that. Go outside. Before we get into that, make sure you share the podcast, rate and review, all that stuff, blah, blah, help the show grow. Go outside. Be a good person. See you next time.